is that an emergency when you stab people in
No,
the intestines? Like, yeah.
And it's like during that entire time when you're in surgery, you are mentally tuned in. There is not a moment where you can tune out. Because if you do, if you're in liposuction, you're not paying attention, you're gonna go in the wrong direction and potentially harm the patient.
If you're doing something that's new, you don't really know what the long-term result of that is going to be. All those patients may be super happy, or there may be significant complications or concerns with that heading towards the future. The rhinoplasties from Dr. Ferda Errol have gone from very viral on TikTok and Instagram, and now they're hitting the kind of standard news. So I don't know if you saw this, but there was an article that came out in the New York Post recently talking about her rhinoplasties. And I know that you've talked about her rhinoplasties on your social media already. I have not weighed in on this one. I know that you were specifically requested to weigh in on it. But I agree with you in many different ways about the rhinoplasties that she produces. And I guess a little background for some of our readers who are either not social media people or just living under a rock. But Dr. Errol has gone viral for some of her rhinoplasties in which she called it the Barbie rhinoplasty, right? Barbie nose? Is that how she
calls it?
Yeah, that's what she called it. But in these rhinoplasties, she has kind of some more traditional rhinoplasties, which nobody has any questions about. But this one specifically, the Barbie rhinoplasty, we're seeing these rhinoplasties where the noses are turned up pretty significantly. And, you know, we in the medical field have this general idea of what is the beautiful normal, and this is a touch higher than that. And as you talked about in your social media, the noses do drop after rhinoplasty. So as dramatic as it may look on the table, it's not going to be quite as dramatic. But some people do have concerns that her Barbie rhinoplasty will be a little too turned up heading towards the future, and that there may be some patients who are concerned about this long term. But the reason why this is a holiday discussion, which doesn't make any sense up until this moment, is that in the New York Post article, they actually said that people are starting to refer to it as the Whoville nose job, which is a little different than the Barbie nose job. So coming into the Grinch Who Stole Christmas, little Cindy Lou with her cute upturned nose, that's what they're starting to refer to it as. Thoughts on that?
Yeah, actually, I was asked today to comment on this in another article, a major news article. Something that's coming out on Friday, specifically the Whoville nose. And it's interesting because, yeah, like I had done a TikTok about this. It's probably been over a month. I mean, I remember when I viewed her TikTok page, someone had sent me the link. They asked me to say what my opinion of it was as a plastic surgeon. And I looked at it, and I looked right away first. I mean, obviously she's in Turkey. And we have to look ethnically at, you know, a lot of the patients, the population that they deal with there. There's a lot of different structures of the nose that we may not see, or it's different than what we may see in the United States or regionally across the world. And so I think a lot of what they're doing is it's cultural, it's ethnic, and it's pushing the boundaries. It's kind of a combination of all three, specifically the Barbie one that you mentioned. And so when I commented on it, I was very political. I didn't, you know, I mean, my personal opinion is, holy shiz, like that is the most rotated tip I've ever seen. And my concern is, you know, if we're talking plastic surgery medically related, you know, what's going to happen to the skin envelope? I mean, yeah, you're going to get some skin contraction because you've kind of shortened that distance so much from the radix to the tip, you know, that upturned nose. Yeah, you're going to get some settling, but what's that going to be long term? And if there's any issues, what have you done to the skin envelope? If you've really taken maybe a fairly, you know, relatively larger nose, shrunken everything down, allowed that skin to shrink wrap like saran wrap around that new structure, you know, if there's any issues, you're looking at major reconstruction if you have to fix something. So that, to me, looking as a surgeon, that's what concerns me the most. And I didn't touch on that in my brief TikTok, but that's what goes through my mind when I see her post specifically on the Barbie nose or the Whoville nose.
Yeah. And for me, I'm all about patient advocacy, right? If somebody comes in, they're like, hey, this is the nose that it's like, this is what I'm after. Very shortened, rotated, and that's the look that they're after. They know what they want. They're going to a person who produces it. She produces it well and they're happy. Awesome. right? It's like, I'm not here to tell anybody what they should or should not have, seeing as though I don't hold the keys to beauty for everyone. I have two concerns with the Whoville nose. Number one, how is that nose going to function, right? This isn't a butt. This isn't somebody's tummy we're doing a tummy tuck on. When you decrease the size of the nose that significantly, what is their airflow really going to be? Because I haven't heard anybody talk about that. It's like, with these patients who have these noses, do you have good airflow through your nose? Because there is nothing that will drive anybody insane faster than not having having good airflow through your nose. I'll get a stuffy nose for like 2 weeks. I'll be like, all right, take it off. Like, I don't want this. So the idea that there's a possibility that there's somebody out there who's had this and that they're not having good airflow, that's a concern. Number two, and you kind of touched on this before, if they aren't happy with it, either because they were excited about it and then were less excited about what it looks like long term, or they're having functional issues, what is it going to take to reverse that? And I think with a lot of the surgeries we do, how difficult it is to reverse, or if it's something that you needed to touch up in the future, how difficult that will be is really, really important. It's especially important for noses. So if they're going in and removing a good portion of the septum, shortening everything, bringing everything in, if you decide that you want to reverse that process, the skin envelope, as you talked about, it's like, is it going to stretch out to where you really need it to be? But the underlying like cartilage structure, if that is gone, you now have to steal from somewhere else. You have to do rib grafts, you have to do grafts from the ear, or something significant to really kind of bring that back. And what is that going to look like long term? So, we see this on table, right? All of these videos, I haven't seen any picture of somebody walking around, 6 months or a year later. It's like, you see all these on table results. What do they look like in 6 months or a year? And what do those patients feel like with that result? And how does it function is another one. Because I don't know if you're going to be seeing like a whole run of patients who were excited about this because they thought it was going to be the whole new thing. And now in a year or two from now, they've decided they want to have it reversed and find out how difficult it would be to get them from where they are back to beautiful, normal, the things that, we measure and look at. I think that's a big concern for me. But who knows? Maybe they're all super happy. And if that's true, that's great. I mean, have at it. But that's the thing that's in the news now.
Some of these patients personally. I mean, she obviously has surgical skill and talent that she's developed and learned.
Oh yeah, no question. Yeah.
So, but she is, as a surgeon, consciously making these decisions, like you said, whether it's trending, whether it's what they're asking for. I think you also have to synthesize, as a physician and surgeon, what's the best thing, safest thing, and the most functional thing for your patients. Because we can do a lot of weird stuff, but it doesn't mean at the end of the day it's the best thing for the patient. And not that we have to tell patients what is best for them, but we also, as experts in our field and doing what we do every day, we can advise them, like you said, knowing the potential complications, potential need for revisions. Those are all things that we have to think about. We don't depend on our patients to tell us that information. We should be educating them on that, and then they make an informed decision. So if in a way, I don't know, I wouldn't call it experimental, but it's like, if you're doing things to patients that they're not really understanding what the long-term, results are going to be, that's a little concerning to me. But anyway, interesting story. I hope her patients are happy.
Yeah. Well, it's like, if they know what they're getting, they get it and happy, great. But you're right in saying that it's not truly experimental, but they're pushing, she's pushing the envelope of what we consider the norm for rhinoplasty. And when you're doing that, if you're doing something that's new, you don't really know what the long-term result of that is going to be. And all those patients may be super happy, or there may be significant complications or concerns with that heading towards the future. That will take time to see. Noses really take time to settle, and we'll have to see in the future. Maybe we'll talk about it next holiday season.
Do a follow-up.
Yeah. What we need to do is we need to find one of these patients and we need to interview them. That's what we need.
That would be amazing. I think that's the goal.
Yeah.
If you're out there, if you know anyone out there, please help us.
Yeah. That's going to have to come from Jerry's following, not me. You get a much higher chance, a bigger shot. We'll see.
Someone will be.
Yeah. If you're out there, let us know. Let us see you. Let us talk about it. All right, this is a survey. Every scientist loves surveys. People in science, it's the best science survey.
It's what they do.
Yeah. So there's an article came out on inner body, And the article talks about people's weight changes and goals around the holidays. And it's obviously it's a survey within the US. But they said that 2/3 of people who answer the survey, and they had like 500 people who answered it, 2/3 of them said that they had significant weight gain around the holiday season, mostly around overeating and not exercising as much, even if they're trying to make that a priority. And they said that 47% of patients would get between 4 and 9 pounds of weight gain, and then an additional 18% would be 10 to 15 pounds. So instead of the freshman 15, it's like the holiday 15. You're just putting on 15 and then trying to take it off the rest of the year, which is
Right. The gyms
wild.
are busy in January, man.
Yeah, well, it's like that, and everybody in their New Year's resolutions. Yeah. I have some changes. I'm not going to say that it's 10 pounds, but yeah, I'll put it on a few around Thanksgiving and Christmas, and just low activity and more eating. But I think that in my practice, and I don't know if this is necessarily true for you, it's like I see a big run of kind of more reconstructive cases towards the end of the year, and then the beginning of the year is like a huge rush of people coming in for body contouring. Do you find that that's true in your practice, or you just busy year round?
Yeah, mine's a little weird. It just never stops. But so I don't really have like that December rush because I don't insurance, but it just feels like a rush 24/7. But yeah, no, I hear that. Yeah, no, it's definitely. I'm not complaining, but I don't see that wave. But we hear about that, and I remember seeing that in residency and all that stuff, and it makes sense, especially when people are trying to meet deductibles for insurance at the end of the year. Like, hey, might as well try and get this, extra procedure done. It's covered by insurance. But then beginning of the year, now you've reset all that, so they're kind of like, okay, I'm gonna wait to do those insurance cases, and so if I do an elective thing, I'm paying out of pocket anyway. I'll pay for that.
Yeah.
So I can see where that makes total sense.
Yeah, and I feel like people don't want to recover during the holidays. Everybody's traveling. You've got a lot going on, and then having that breather afterwards, it kind of makes sense. But I think
it's still winter, like, so people are, the worst part is like lipo and things where you have to wear compression. No one wants to do it in the summer. So a lot of people like I said, that time frame where it's right after the holidays, still cold and all that.
Yeah. And I think that's a really good point. And I think that when people are talking about significant weight gain around the holidays, obviously the first thing that people would think, instead of having to pay attention to what you're eating, go to the gym, it's like lipo's the easy way out. But I think there's this huge misconception in lipo in general, because people think minimally invasive. So they think minimal downtime and super quick results, which it's the exact opposite of that. I mean, what do you tell your patients in your practice about when I have lipo, significant lipo, obviously not like a small area? What do you tell them the time frame is when they're going to see their final result?
So I have a very specific time frame I tell them, and I've actually now gone through it myself recently. Just having had my partner, Dr. Garlic, do my 360 Vaser lipo on my abdomen, chest, back, all that. Yeah, so what I tell them is, look, first off, you're going to have to be wearing compression. Your body is going to freak out when we remove a lot of that fat. There's a lot of swelling, a lot of fluids going in, a lot of fat and fluids coming out when we do liposuction. And that creates a lot of trauma within the tissue underneath your skin. So your body's going to react by swelling, and that swelling can be pretty significant if it's not adequately controlled. So I tell them, look, in the first 6 weeks, for sure, it's super important, at least in my practice, to do lymphatic massage and drainage. We offer that in our spa, but we start initiating that day, post-op day 1. And people always worry like it's going to be painful. It's actually it actually feels better because the lymphatic specialists are able to mobilize the fluid and get it out into your lymphatic system, into your bloodstream, and then you pee it out. And so that's huge. But I tell them, look, for the first 6 weeks, you're doing lymphatics, treatments at least once or twice a week. And then compression is just really annoying for patients, but you have to wear it. And you got to wear it. I tell them 3 months, pretty much nonstop 3 months. You add foams for the first 6 weeks. And then after the first 3 months, you can start to taper off the garment as your swelling gets better. But I tell them you're really going to see your final results around 6 to 9 months. And everyone's a little different, but I say on average about 6 months. So it's a time commitment, and it's a mental game too. I know you have experience with this, Sean, but there are times, even myself, where I'm like, geez, like, why did I do that? Or why do I look like this even though I had that done? You know, like you kind of play these games with your mind. And so I think a lot of that also makes the recovery just seem longer, even though you actually are doing a lot better. And we kind of forget what we looked like before. And that's kind of what I do. What do you tell your patients?
Yeah, I tell my patients it's very similar. I tell them strict compression for 6 weeks, and I always say preferably 3 months, knowing that some patients are going to give it up after 4 weeks. And then I always tell them once you get to that 3-month mark, you can start to transition out, and you can go from our medical grade compression to shapewear of some sort. And I have a good number of patients who will wear it, out to even a year. I've had some patients that feel like addicted to it. They're like, okay, I've never came out of it because it just feels so snug and I really like the way that it kind of looks. But you'll have some patients that'll just stay with compression wear. But I do tell them for most patients, I'll tell them like 6 to 9 months for recovery for liposuction. For people who I'm doing larger volume liposuction, I'll tell them like 9 to 12, just because we know that it's going to take them longer. It's like the more lipo, the more swelling. But I think that when you look at that time frame and you're looking at a lot of these cases happening in the January, February time, which is perfect because you have surgery, you're in compression when it is cold and miserable outside and you don't have to worry about being too hot. But when you start to think about how long it's going to take to see your final result, at least that aligns you of having the result that you are after in the summer months instead of having it in late winter, early spring, and then you're still swollen and still dealing with compression when you're trying to go to the beach or wearing a bikini, and then you're going to get your final result next Christmas, which is not as helpful to folks. But I think that's a real issue with lipo is everybody thinks it's going to be this quick fix. You're like, hey, I put in 10 pounds during Christmas. I'll have a little bit of lipo. I'll look great by Valentine's Day. And the turnaround is not that. They have to be prepared for that.
Yeah, I like that you prepare them ahead of time because again, it's always about managing expectations. It's something you and I do every day in clinic and before surgery. It's really reminding patients and educating on how this process works because it's not instantaneous. Instagram and TikTok want to show befores and afters, and I'm guilty of showing that, but trying to explain it through the captions. It's not instant, but people just look at 2 images and think, oh, that's instant, and like I said, it's a process and it takes time. So.
Well, people do the transition with the finger snap. It's just that fast, right? They do it for the surgery as well. It's like, this is a 6-hour surgery that
does that thing, and the nose is,
That's all it takes, and just from the side. Looks nice. Yeah. But yeah, for all of these surgeries, it's like we do these snaps, we do these quick transitions, but it is a process. And I feel like every patient, they have their good days and their bad days. They'll feel good about how things look one day, and then other days they'll wonder why it's taking so long. It really takes time to go all the way through it. And it sounds like you had that. And when I had my liposuction, I was the same way. It's like 4 or 5 months later, I'm like, oh my God, am I still swollen? Is this, it's just taking time. It just takes time. You just have to trust the process and stick with it.
Yep. Agreed.
All right. So I want to talk more about lipo because number one, we love it, right? We're plastic surgeons, even though originally it wasn't even made by a plastic surgeon. It's a stolen technology that we use to build our entire practice upon. But I feel like, just like when we talked about, there's misconceptions about liposuction and the time frame and the downtime and all these things about how people think that it's a quick fix. I also feel like there is a lot of research that people do on their own for these ideas of technology that if the technology is right, that the result will be perfect. And I feel like this is only true with lipo, for me at least, that when I get DMs from people for, say, a facelift or a breast aug or whatever it may be, they ask me a question about it, but it's in general my view on what breast size do I think is best, or how do I do blankety blank. But for liposuction, I'll have people contact me and they will ask, what machine do you have? What settings do you use? They're really, really far down the rabbit hole. And it feels like there's zero trust in my opinion on the subject. I don't know, they're on Facebook groups or Reddit or whatever it may be that people are giving them these ideas of if it's not Vaser liposuction, then it's wasted. If it's not laser liposuction, then it can't be good. So they're looking for these very specific pieces of equipment because they feel like if they can get that equipment in the room, regardless of like whose hands are doing it, they're going to get the result that they are after. Because I feel like when I answer these DMs, I'm like, this is the hardware that I have. It's like, some people will be like, yes, perfect, let's get it going. And then I have other patients who are like, okay, that's not what I'm looking for. I'm like, you're looking, you're not looking for a plastic surgeon. You're looking for equipment. And I find that very interesting because I don't see that with other things. Do you see that in DMs you have, or people just like trust you inherently to do what you want to do?
I think I used to get a lot of those questions, and I think a lot of that stems from social media people, whether it's from companies, like there's certain trademarked companies that label it as like they do everything with their system, right? And if it's not the AirSculpt, then it's the wrong system, right? So there is this big marketing push. So a lot of it is marketing from companies that have trademarks on these names, but in reality, and maybe we've talked about this in a previous podcast, but I mean, really just combining things like Renuvion and ultrasound, Vaser and micro air PAL to call it their AirSculpt, and then add Ovally in there. And so they're kind of bundling these technologies, but then people hear the word AirSculpt, or they hear laser liposuction, smart lipo, right? There's all these terms and trademarks, and those are buzzwords like you mentioned. And I think a lot of this was also perpetuated by websites like RealSelf, where you could look up these technologies and then find surgeons in your area who use them. And then, like you said, Facebook groups, and then social media. So a lot of it's marketing tools, probably by these companies or by actual plastic surgery or non-plastic surgeon companies pushing it. And people just hear buzzwords and they think that's the way to go. Now, for me, I don't get those questions as much or really anymore, but I think if you're able to put out a lot of content and show, hey, when I do this, I do Vaser liposuction. They know what I'm doing when they look at my page. And if they're looking for AirSculpt, they know I don't do it. They're not even going to ask me. They're probably going to go somewhere else. So I think those questions, that's why they've gone away. Maybe it's not that they trust me, but they see what I post about and they're following me for a while before they decide to DM. A lot of people, some people will just like follow you and then DM, but some people follow you for months. I've had people follow me for years. So I had a lady the other day, so I've been following you since you were in fellowship in 2017 when I started my account. I was like, wow. And she's just DMing me, and so people are watching, but they're really watching your content. They're watching your results, your befores and afters, and they're reading everything you're saying. So if you're saying, yeah, I'm doing, whatever, Renuvion, skin tightening, they know it, they read it. And so I think maybe that's why I don't get it as much, but I did have it in the past. And again, I think it was driven more by other marketing tools.
Yeah. And maybe we should talk a little bit about tech in liposuction and the tech kind of around liposuction. So I feel like there's a lot of misinformation, and I also feel like patients mix up things a lot. Mm-hmm. People will mix up like Vaser and Renuvion, which are like totally different technologies. It's like they're used together with liposuction, but have very different purposes. Mm-hmm. I think it would be helpful to kind of go through some of those to kind of really define those so people know what they are kind of heading towards the future. So I don't feel like people are doing a really good job of that. I feel like there's a lot of advertising that goes out there to say like, well, you need it. Now what it is, they don't know. They just know that somebody told them that it's going to be necessary for them to get the result that they're really after. So I think like liposuction in its simplest form, right? We put in fluid to numb you up. We suck out fat. And the easiest form of that is hand lipo, which I don't think we do with any I don't do with any regularity other than taking like little tiny bits of fat that I'm going to use for facial fat grafting. I don't know if you use it for anything, but most of the time what we're using liposuction for is not just hand liposuction using syringes, but using actual suction assisted liposuction where we have a machine that is producing significant vacuum. And I know that in your practice, you almost never use just suction assisted liposuction, right? Because you're either doing power assist or Vaser or like something else, correct?
Yeah, because even like if I'm in clinic, let's say I'm doing Ovally, I'm doing dimpling or cellulite release on the buttocks, and I put fat grafting in there for spacing it. If they're awake, I still have my micro air in clinic, so we have one in there in our procedure room. So we would just put the fluid in that area, let's say the abdomen, take a little bit of that, and then doing the buttocks. So I don't do much SAL or suction assisted lipo by hand. Honestly, I don't even have the cannulas to do that because this is different plug-in. Now I have done it though in submental lipo on awake patients. So it's a little uncomfortable for an awake patient to have a micro air machine just like vibrating in their neck, hitting their margin-mandibular nerve and doing weird stuff.
Yeah.
So that is one area that I will do, and I did a TikTok about that. I showed a patient, she was wide awake, and I did that's SAL in clinic. But that's probably the only time I personally do it. Are you doing it? Do you like to do it for like awake stuff, or when are you typically doing it?
So I use it in our clinic for awake stuff because we only do small volume stuff in the office, because I don't use micro air in the office because all of our micro airs are living out at surgery centers or hospitals. The other time that I'm like pigeonholed into using like standard SAL is when I'm at a hospital that doesn't have micro air. And those are the days that I'm cursing having to do it all by hand. And for people out there who don't know the difference, it's like a micro air power assisted system where the cannula goes back and forth very quickly. So you only have to do smooth strokes versus a suction assisted liposuction setup. You have to move it completely on your own constantly as you're going around. So it ends up being a significant arm workout. So when I go to those hospitals, when I'm doing breast fat grafting for breast cancer or body contouring for around breast cancer, when we're doing the lateral chest wall or whatever it may be, I use it for that. But I use it the same as you do in clinic where I'm doing neck, but that's because that's all I have. But I'm not doing any larger volume liposuction stuff in the office. I take them all to outpatient surgery centers for that. Yeah. So we go from suction assisted liposuction SAL to power assisted, so PAL, and this is the terminology we're throwing around. Micro air, which is just the company that produces that. They're not the only one who does, but I think that I would say that they're by far the most popular with plastic surgeons. Would you agree for that?
Probably in the United States for sure, I think. And there's a few other devices that are very similar that have an oscillating, end piece that you attach the suction cannula to, and then those are interchangeable. So the handpiece itself has a little adapter, so you plug on the cannula, because cannulas are all different shapes and sizes. Some are longer, some are shorter, some are 5 millimeter, 4 millimeter, 3 millimeter, right? So the finer the cannula, the smaller it is, the more fine you can get, and actually the more superficial you can get. And then we'll talk about ultrasound assisted lipo in a second, but I think the micro is a very powerful tool because, I compare it to, I remember when I was younger, we lived, before I moved to Saudi Arabia, I remember my dad, he had a push lawnmower. You ever seen those? Like the blades, you actually physically push to spin it, and then it cuts as it spins, but there's no motor. And I remember trying to do, I was young, it wouldn't even budge. Like it gets in long grass, you're hosed, like it's not going. And so I kind of imagine SAL is the same way. It's like you're trying to go, and we could do it. I know how to do it, but it's just so much more effort. Like you're saying, it's more work to do the same thing that you're trying to do. And this is like, for me, like the amount of lipo we do in a day, I do 5-10 liters a day, and between, 2, maybe 3 patients. So my arms are dead. And if I had to do that without power assist, the 1,000 times per minute, whatever oscillating power that we get, I wouldn't be able to do my job how I do it. So, I think at the same time, a lot of these tools that we have enabled us to do things, I think, more efficiently, and I would say more safely, because, instead of me fatiguing out on a case and accidentally going the wrong direction with my cannula, I feel like I have much better control. I feel like I'm not having to force things through. What I kind of imagine is this cannula is going back and forth, like 1,000, whatever it is, cycles a minute. And it's essentially finding the path of least resistance. So as you're going the direction you want to go, it will find the path right along there instead of having to force it through tissue. So that's what I really, really like about the PAL. Yeah. I use it every case in the OR.
I also think that when you get tired, right, your end point, when you are truly done, will come a little faster if you're doing suction assisted versus power
300
assisted.
300 cc's is good.
But it's not like you're going to give up. You're like, like super tired with it. But if you're getting really worn out physically, right? Mm-hmm. We're both 43, right? I don't go to the gym with any regularity. It's like the only workout I get is like all of this is that that's just lipo. That's all I got. There's nothing else.
My upper body is pretty big and it's from lipo.
It's all from lipo.
Relatively.
It's the only workout I get, but if you're getting tired because you're doing a ton of lipo, say you've done like 360 on somebody and then the next case you're doing 360 again, when you're getting towards the end of that, you're like, your brain is trying to tell you that you're done and you have to tell it to shut up because you're like, I know that I've got a couple hundred more CCs coming out of this side because I know that it's got to be even. But there's like this little voice back there that tells you like, hey, are you sure you're not done yet? Because you'd love to be done. So the idea that you have something that makes your job easier, I also think will make you get to the end point that you're after because you're not exhausted and wanting to be done. You're like, okay, now I can take another look at this. And if I need to take another shot at something, I've still got the juice left to get it done. But I think that is important to note that if you're just doing SAL, at some point you will literally fatigue to the point that you're ready to be finished, and that can affect the long-term result.
I think, I totally agree. I think there's a component of not just the physical fatigue that happens with plastic surgery, like these types of cases where it's very physical labor, but the mental, energy as well. And I talk to patients about this because they're like, oh, you operate from, 6:37 in the morning till 6 p.m., between cases. We have a little break. And it's like during that entire time when you're in surgery, you are mentally tuned in. There is not a moment where you can tune out. Because if you're doing liposuction, you're not paying attention, you're going to go in the wrong direction and potentially harm the patient. So the lipo is not, it's hundreds and hundreds and maybe thousands of strokes, right, that you're talking about. But every single one matters and you cannot lose attention. Now, I think we do it so much that we can feel, we know our hands are kind of doing things a little subconsciously, but we can never tune out because we're always assessing how much is going in, how much is coming out, how much have I taken from this area, how many passes have I done, have I passed through the same area more than once, is it too thin here, do I need to smooth this out, am I near any vital structures? You're always thinking, like these are all the things in my head as a plastic surgeon. I'm talking and we're doing it, but this is all going on in the back of my head, right? And I'm sure it's the same for you. And, we're constantly doing that. And then when you're doing, breast surgery or tummy tuck or facelift, you cannot tune out during any surgery, And I think it's that mental energy that is, I think, the much more difficult part as a surgeon is to maintain that over a long day and to do that
super
day in,
exhausting.
day out. It's a lot.
Yeah, patients ask me that on a regular basis. They're like, okay, this surgery is scheduled for 6 hours. Are you in there the entire time working, or you like take a break during it? I was like, no, I don't take everybody else in the room gets a break, right? It's like, we don't get a break because patients are paying for that time you need to be working. But people ask like, how can you sustain really intense focus during that entire time? And it's built up during residency, and now it's like ingrained. This is just what you do during that time. And people ask like, don't you get hungry? Don't you get thirsty? Don't you have to pee? And you don't think about any of those things unless you're like, there's a break during surgery that you're not having to pay attention because patient's flipping or, they're doing a position change or whatever it may be. But during that time, you don't think about any of those things until it's done. And then it's all of those things very intensely that come back to your mind. You're like, quickly, okay, I finished this 6 hour surgery. I need snacks. I have to pee. I gotta have something to drink. But the mental strain during the surgery, which doesn't feel apparent at the time, also comes rushing back at the end of surgery. It's like the world and all of your mental and physical needs come back at the end of the surgery, at which point tired, hungry, all the other things kind of come together. Yeah. But you never have that sense during the case because you are just intensely focused on making sure the patient's getting what they deserve during the time that you're putting in.
Yeah.
Let's talk about laser lipo, because you used to have a Beautifil, right? Mm-hmm. Yep. Do you still have Beautifil, or is Beautifil gone?
I don't use it. I have it. It's collected dust for the last 4 years.
Oh no, poor Beautifil.
A little Porsche sitting right there, in my office.
Just hanging out.
Not hanging out.
How much is that machine that's not getting any work? How much does that set you back?
It's over $200,000, man. Like, those machines are so expensive, So, and I got that early on, and not to dog on any company, but it just, the day I bought it, it was a lemon. They had to give us a new device, And that was frustrating. It was nice to work with them. I mean, they were helpful to get us a new device and things, but that to me should have been a red flag when they're like, well, there's no test driving this thing. You just got to buy it to use it. I'm like, what? So I was early on a little naive when it came to buying devices. Now we're much more sensitive to that and try to look into the ROI on each device, put together a pro forma, what's going to take to pay this thing off. But yeah, I bought that device early in my career, and I thought it was good because it helped position me, and I actually really liked the idea and the technology. It's like, hey, you suction into this device, it captures the fat, you then can turn that fat right around and inject it, and you do it all through this laser cannula. And essentially there's like a laser fiber that you put into this cannula, and you have to change it every time because the laser breaks and all this stuff. But laser really, I mean, it's emitting energy, right? So the whole claim is that as you're passing this through, it's emitting this certain frequency of laser energy that's going to help break up the surrounding structural tissue of the fat and allows you to suck it out. And at the same time, heats up the tissue to tighten it. So conceptually, it worked great, and I liked it. I never had any burns with it. I had good, I think outcomes. But we always hear those horror stories of other devices, whatever, of like getting burns at the thigh or other areas where they were passing the laser through, and I think the technology's come a long way from that. But for me, I think when it comes to energy, I do think less is more in a lot of ways, especially if you're trying to treat all these areas for certain things, and so. I've personally gone away from that. Like I said, I haven't used it. I think there's other modalities that are a little more reliable, a little bit safer, and I can get consistent results, but that's just my opinion.
Yeah. And with the laser lipo, so you've got Beautifil, there's Smart Lipo. What are the other brand names of lasers? I'm trying to remember.
I mean, those are the two that I remember that are around.
Those are
like
the biggies.
There's a third one, and it's older. I don't know if you can even get anymore. That was around at the time when I got my Beautifil, but that kind of phased out. I don't even remember what it's called, but yeah, there's not. I don't know if laser has been such a big push lately for liposuction that I know of.
I think was it Cyanoshore? I think was another one. Can't remember.
Yeah, I know they have a few different devices. It might be one of them. Might be a laser lipo.
Yeah. And I think it's one of those things where you're trying to package all the goals for liposuction in a singular device, which sounds great, but if it does all three of them not awesome, then it's not what you really want. But having the laser, break up tissues, that's what Vaser is for, right? That's what we use Vaser for. That is these ultrasonic technologies have been around for decades at this point. That's like tried and true. They continue to repackage it and change it under kind of different companies' names, but that's something that's been around. And it's like, does the laser from Laser Lipo work as well as Vaser? I would argue it doesn't. It still sucks things out, which is awesome. Still works like standard lipo. And then when you look at what it refers to, talking about skin contraction and tightening the skin, even when you look at the paperwork from Beautifil, I think it either says mild or minimal. It says like minimal skin tightening. Like that's what they're pushing even on the brochure. They're not saying that you're going to get a huge change from that. So is it a replacement for Renuvion, which is made specifically for that? And I would say it's also not a replacement for that. So they've tried to get everything together in one package, but it didn't quite meet the mark for all the things it was trying to meet. And if it did, that would be great, because if you take Vaser and Microwear and Renuvion and smash them together, you would have a heck of a cost savings buying just a single system that was going to do that. But I just don't think that it kind of meets that.
Well, I think, the issue I personally had and why I kind of parted ways, I used to actually speak for them and give a lot of talks. But what I realized was, and I would do trainings, but they were trying to push a device, an all-in-one device like this, to make it sound so easy and safe to do that anyone could essentially do it. So they were selling this device to nurse practitioners, physician assistants, family practice doctors, ER doctors, and I know because a lot of them tried to come to my trainings, and I had refused to come, and I said, look, I will only train plastic surgeons and plus or minus dermatologists who have experience in liposuction. I wasn't going to do any beginner courses because, for me as a plastic surgeon, I just felt like that is a very unsafe thing And actually one of the questions I got, so the very first training I did, I was told there were going to be all plastic surgeons there. It turned out not to be that way. One of them was an ER doctor, and I was like, what the heck? And it was after that day I said, I'm never doing this again. But one of the questions he asked was like, so if I get into the bowel during liposuction on an awake patient, is that considered an emergency? And I literally, my jaw dropped under my mask. I was in the middle of doing a procedure on an awake patient. My scrub tech looked up at me. She realized that what I was thinking, we were thinking the same thing. And I looked at this ER doctor and I said, you know what? You either rush the patient to the nearest emergency room as fast as you can, or you call 911 to get an ambulance. Whatever is faster for you, you do that, because that is absolutely unsafe and is not an expected outcome and should not ever happen. And if it does, you got to take care of it. This is a legit question from an ER doctor.
I was going to say, if this is from an ER doctor,
you should know. Bowel perforation.
You should know what an emergency is. That's what you deal in, is emergencies. Oh my God, that is wild.
That's what scared me, is they really try to package this because it's like, hey, this is so easy to do. You turn it on, you suck out fat, you put in fluid. And I remember after doing that training, several of those people asked me, like, I don't feel comfortable doing this. Like, even after you taught me this, you did a great job, but like, this is not my scope, And these people had already bought the device. Now they're like, I want to do this 200 something. Yes. What do I do with this $200,000 something device that I don't feel comfortable using, And I just did not appreciate that approach at all. I felt that it was just not in line with what I, kind of believed in. And so that's
sell it first and figure it out on the far end as far as patient safety is concerned.
I mean, we know about this from, laser companies. What's the quickest way to get a laser, rep out of your office is to buy a laser, right? That's the old adage. And that's not true for every company. We have some great relationships with Saiton and, some of these other companies, but that's the running joke, right?
I can hear the angry emails now.
Well, bring it. I can speak from personal experience. I'm not going to say it. No, I'm just kidding. No, I mean, honestly, there's some really good representatives for different companies and great companies with good products. But, it just concerns me when we're trying to really simplify something that is surgical, to label it as something that is not. That is just what irks me.
Yeah. And market it to people who aren't surgeons, who even after appropriate training from very skilled personnel feel themselves uncomfortable. And you worry that some of those people who didn't feel comfortable, didn't speak up, still use the system because they feel like they're in for it for enough money that they have to do it, and could hurt somebody.
Yeah.
Wow, that's crazy. But yeah, so my God, just like, is that an emergency when you stab people in the intestines? Yeah.
That's sorry. Just because, but I was
just because it's a sterile stabbing to the bowels. It's like if somebody got stabbed in the guts on the street for their purse or something. That's an emergency. Yeah. You got to do something about that and report it to the board, or at least we have to report it to our board. I don't know if the emergency room doctors have to report it to their board or board of cosmetic surgery. I don't know about that one.
I don't know.
All right, so next tech, Vaser. How long have you had Vaser for? So you had it after your Beautifil, so you used your Beautifil.
Actually,
using 4 years ago?
No, my Vaser was the first device I purchased.
So you had Vaser even before.
I had it, yeah. Huh. So because what I was doing, and the reason why I was interested in Beautifil is because they claimed it as an all-in-one system, right? They said, look, you're gonna heat the tissue, you're gonna tighten it, you're gonna suction it, you're gonna tumesce it, you're gonna fat graft it. And I was looking at my Vaser. I was getting like a revolve system to get the fat. I was using Vaser to tighten and also prepare the fat, like we talked about, ultrasonic energy. And then I was using the PAL to suction. And I'm like, well, if I could just do one device, that's what I'm going to do. And I remember I'd sent a video of my whole contraption I had set up with my Vaser and all that to show how I was fat grafting. And so I was super excited about the Beautifil, how they had it set up. But I had my Vaser, honestly, and I tell a lot of new surgeons coming into private practice, because they ask me all the time, hey, what device should I get if I'm going to buy a device, right? Because in our minds, I think we're like, okay, what do I need to stand out? What do I need to say? Like you said, people DM you and say, do you have Vaser? Like, oh, I have Vaser. Come on, And so I think there is something to that. It doesn't mean you're going to have a great result, but you have it, the device. But I got Vaser, and I tell people, look, I would invest in micro air first. So, save yourself the labor. Everyone, we all do liposuction. We do a lot of it as plastic surgeons. So definitely get a micro air or a PAL system. And then secondly, I would combine that with the Vaser. And that's more, aimed at, a couple of things, right? So we think about Vaser, we think about we're using ultrasonic energy, again, to essentially separate out the fat and the connective tissue to allow the suctioning portion of the surgery to be a lot gentler on the tissue. Maybe even you could suction more superficial, right? So when we talk about, that's where the high definition comes in that Dr. Hoyos coined, and they train and do all this high definition liposuction where they're really using ultrasonic energy to get that fat from right under the tissue and then really etch out, let's say, your six pack or your deltoids or your calves. And that you can't do that consistently and super well with just power assist. You really need to get under the the dermis and in that tissue with the ultrasonic energy.
Yeah.
That's kind of the thought process behind that.
Yeah, I think for listeners out there who don't know the tech that well, it's like Vaser, the whole point of it is you have a cannula that you're going through the hole that you're going to do the liposuction through. It emits ultrasonic energy from the end of the device, and it's breaking up that connective tissue. And I think that the easiest way, and the way that I talk to patients about it, is that you really have two layers of fat. You have skin, you have superficial fat, there's a connective tissue layer, and then there's deeper fat. And standard liposuction is pretty effective in this lower portion, but you don't get a lot in the superficial compartment. But with Vaser breaking up some of this connective tissue, it gains you access to be able to take out a little bit more. And that gives you the ability to do these kind of high definition 3D, 4D, however many D lipo people are doing nowadays. Yeah. But it does seem more effective, and also the speed in which the actual liposuction occurs is faster, so it's easier, physically easier on us.
I love it. I'm especially for lower back liposuction. So there's certain areas like I always use it, like lower back. That is just fibrous, thick tissue.
It is hard without
that
Vaser.
Tissue. Yeah, I don't know what I would do. It's just like ramming. And if I had to do hand assist lower back, like I'd rather not be a plastic surgeon. I'd rather go read pathology slides all day. At that point, no offense to pathologists, but
they're like, hey, I like my job. What's wrong with you?
Yeah, as long as you like it, that's great. I'll keep sending them to you, the slides, sir or ma'am. But so the lower back, and then secondly, there are like connective tissue bands. There's actually, people get those back folds. I think those are great to break those up. You can actually kind of break through those with the ultrasonic energy. And then if you've had previous liposuction, that's another great area because you have scar tissue now. You have more connective tissue kind of haphazardly organized from the previous that. So that's a good way to help with revision liposuction to help smooth things out. And then lastly is, the paradoxical adipose hypertrophy that you see that can occasionally happen after cool sculpting. That fat that grows after they tried to freeze the fat and does the opposite sometimes. That stuff is hard. I think we talked about this before, but you really need ultrasonic energy to do that, in my opinion. Otherwise,
really strong arms.
It's concrete. Yeah.
I think the other place it can be helpful is chest for males, because it could be more fibrous. And then sometimes this like bra roll fat for ladies, which can be fibrous, that has like some amount of breast tissue mixed in with it. I think that breaking that up can be helpful as well, because that can be brutally hard to get through with just power assisted liposuction.
Yep, totally. A buffalo hump, I think it works well. The pad that people get back here, that tends to be very fibrous. What else? So a lot of surgeons, and you'll hear patients ask about now is lipedema. Patients that have lower extremity kind of excess growth of fatty tissue and all that. That's a kind of a different process. And so I know, a lot of surgeons are using, again, water assisted liposuction. I use that in training. I don't know if you ever use that. They do whatever they claim that helps with the lipedema, but Vaser is another technology that a lot of lipedema patients are seeking out because that's what they've been told on Facebook works best.
Yeah, that is a diagnosis that I'm actually seeing more and more of under insurance. And some insurances actually do have like a broken down plan. Like if you have these 18 things, you can get your liposuction of this one specific area.
What's the toe test? The big toe? There's like some kind of...
Oh, yeah. It's like a pinch test to see if you have tenting, to find out if you have lymphedema or swelling versus lipedema. And you have to take specific photos to show dimpling and all these kind of things. But I've just this year started to see people who are coming in under insurance, but I have yet to see a patient who meets the super high requirements for it. So I don't think a lot of it's going to be covered on insurance. But I am seeing more and more patients who've had like huge areas of liposuction done, cosmetically because it was, they felt it was lipedema associated. So I think that's something we're going to see a lot more of heading towards the future, because I think that a lot more people are getting diagnosed with it. And I also think that a lot more people just in general know of its existence and the possibility of having liposuction covered under insurance, that's the dream. Right? As long as you have a nice outcome, that's the dream.
Well, it's pretty wild. I mean, they will essentially like regrow, or the fat will essentially almost regenerate. Not that they're growing new fat cells, but I mean, those fat cells that remain expand pretty rapidly. Some of these patients are needing repeat liposuction again within months, And so it's a problem. It really is for patients that truly have it. And, and there are people around the country that claim to be lipedema specialists, and it's maybe because probably they do a lot of cases, so they are better probably recognizing some of these early on for patients and listening to them. It's a hard problem for people, and I feel really bad for people that really do struggle with the lipedema.
Yeah, but I think that's something we're going to see a lot more of in 2025 as we're moving forward, because 3 years ago I had never heard of it, and now, as of now, it's like I'm seeing it pretty regularly. At least people carrying the diagnosis or having already had liposuction for it. So I think that's something we're going to see a lot more into the new year.
Yeah, I agree.
All right, let's talk Renuvion. So this is something that we both have. I actually had it done on me, which is why I have the machine. Tested it out first. That's how I figured out that I wanted to get it. And then you didn't have Renuvion during your procedure, but you have it and believe in the tech. Yeah, Dr. Garlick said that you couldn't have it.
I did ask him. Well, there is a new FDA approved device called Quantum, which is by InMode. That it's actually a thermal based skin contracture device similar to Renuvion, but doesn't use helium radio frequency. So that's why he didn't want to use the Renuvion on me, because he wanted to use that, and then he ended up not being able to. They didn't ship the hand pieces in time. Anyway,
unfortunately.
I love Renuvion. I am a speaker and stuff for them. So just full disclosure. But I've been using it for, pretty much. So one of the surgeons in our center, when I was opening my practice in 2020, he had bought, I think, the first Renuvion in Utah. And so, he wasn't using it all the time. So I started using it here and there. And I really liked it. I really liked what it could do for the arms. And I think it's been revolutionary for certain areas on the body that I think before, even when I was in training, we'd have to cut that stuff out. I remember we did so many brachioplasties on the arms because, even if it was just a mild amount of loose skin and fat, nothing we could do. We had to just cut it out. Now with Renuvion, and, you combine it even sometimes with Vaser and obviously liposuction, I really think the arms are a great place to treat. And I've gotten pretty aggressive on these where, you almost will look and say, I think they need brachioplasty. And I've been so surprised that actually it will just contract right up, looks beautiful, and patients are super happy. So you do get the secondary contraction with the Renuvion because of it uses a helium gas combined with radio frequency to create that purple plasma energy, kind of like the purple behind me. And it looks really cool. Remember those globes that you put your hands on, and the Tesla
it's a plasma ball. I mean, that's what it is. I always tell people, it's like, you remember in the mid 80s where at Spencer's Gifts where you had these gigantic things that look like lightning bolts. It's like, that's what it's going to look like, but it's going to be under your skin.
Yeah. And it heats up the tissue, to a very specific, whatever it is, 82 degrees Celsius. So it gets really high pretty quickly and then decreases. So the heat time is very short, but it's enough to stimulate the collagen production, the elastin production, elastin production, and then that secondarily causes the contracture. And and anytime I talk about it, and I've talked about Renuvion, it's like you can't say that it's skin tightening. It has to be
contraction,
coagulation, and then contraction secondarily, or whatever. I don't know.
We know it works. That's what's important. And I think that arms are a big one, absolutely, because having a brachioplasty scar is brutal. I think that the people that I do full-on brachioplasties for are just the massive weight loss patients who have just a foot of skin. There's no way that's going to magically disappear. But I think that there's also a space to be able to use it in kind of hybrid procedures. So you have a brachioplasty, we're doing a large incision. You have minimally invasive where you just are doing liposuction and then Renuvion for it. But doing a hybrid procedure where you're doing incision in the armpit, the short scar that was a surgery that we came up with to try to get away from the large brachioplasty, but we found out it's not that effective other than this kind of portion that's usually pretty lax. But doing lipo, doing a short scar, and doing Renuvion for people who are that kind of middle of the road, we were like, oh, I don't want to have to do a full brachioplasty for them. We can get them what is going to be best by using those two kind of technologies together, I think is a really functional result for people who are not a candidate just for the minimally invasive result. But upper arms, absolutely. The neck, I think, is a great one. I'm like, if this wasn't hidden by a beard, I would have already had one of my partners do it. It's like,
the neck is
great. It's like I would love to have that tightened up. But I think that one is huge because when you think about what was available prior, you're like, okay, well, we can do a neck lift. We can make an incision here and tighten up things, but we can't get rid of any skin. And if you need to get rid of skin, then you need a facelift, or you have to do, RF microneedling, which is only going to work so much. But it's nice to give folks another option for that. I think upper back brow roll is a big one as well.
Love the back. I tell patients, and I do a lot of full back lipo. Anytime we're doing a mommy makeover, takeover, 360 lipo, Renuvion, because I tell them, look, I can get a lot more fat out because you get so much contraction with just regular liposuction. The skin will naturally have a little contraction to it. But if you are pretty aggressive with the liposuction, and then now you're just mostly skin, that skin's going to want to drape down and hang. And I've seen it where patients have actually had almost more skin folds after because you've removed too much fat. So I really tell patients we got to shrink wrap that down, and the Renuvion helps us do that. As soon as we liposuction the back, it's just like shrink wrap. And I'll show them photos, and they're like, oh yeah, I definitely want that. Because you get rid of those lines I was mentioning earlier with the Vaser, you reduce the volume, and you just get crazy contours through the whole back, and I think the Renuvion's great for that. I think the inner thighs is another really good area because that skin there is very thin. It's very similar to the arms in terms of its thickness. And again, you kind of talk about, inner thigh, like medial thigh-plasty, short scar. Again, they have, different versions of that. But I do think in the right candidates, we can get a little bit more fat out and a little bit more tightening without needing a scar. So I think it does just kind of open up the window for more patients to not have a big old scar.
Yeah. I feel like thighs, I don't think we have like the right answer for that. I think that we have so many things dialed in for breasts and so many things dialed in for tummy. The arms, you get good results, but I feel like as you continue to go down the line of things that we feel like are truly, truly effective surgeries, I feel like the thighs are pretty far down. And there was actually an article that came out not that long ago looking at like the highest complication rates in plastic surgery, and the top one was adding, it was keratopigmentation, which is, changing the color of your eyes. Skip on that because the complication rate's super high. But when you look at that top 10 list, I think it was number 3 was thigh-plasty, just very high complication rate from poor scarring to poor contour. But, you talk to people, especially when they have a lot of volume and they have really lax skin, you can pull on that skin with your hands like all day to see how much better it's going to look on the inner thigh. But it translates absolutely nothing to the far side because everything is so tight and connected down versus the back and the tummy and the breast where you pull in one place, it like smooths the entire thing out, which makes it so incredibly difficult. And I'm sure there's some super genius out there who does nothing but thigh plasties all day, every day, who has it like really dialed in. I don't know who's the person for that, but we really need somebody out there to like come up with some sort of new magic for the thighs, because the thighs is just, it's a tough thing. And I always prepare patients, we've done their breasts, we've done their tummies, we've done the neck, we've done the arms. They're like, okay, now I want to do the thighs. I'm like, that's fine. Let's just make sure that we understand what our goals are, what our capabilities are going to be, because it will be the least satisfying of all the surgeries that you have had. I mean, there's other ones that are tougher, but I feel like that one is just tough to enact a real global significant change that gets them to where they really want to be.
And
maybe that's just me. Maybe I'm
issues.
just bad at thigh plasties. I don't know.
No, but I mean, I think you're bringing up a good point. Like it's complex and there's issues because it's not even just the loose skin and the stubborn fat, There's, cellulite, there's dimpling that can occur kind of all over. I mean, you can be mostly posterior and posterior lateral thigh, but you can get all in the front of the thighs too. And so even if you're tightening the skin, you're going to have, these dermal puckerings, these dimples, these cellulite areas that you have to treat in a different way. And like I said, the skin quality, if you look at the skin on the inner thigh compared to like the outer thigh, the skin actually feels different in terms of thickness. So you have these like differences in tissue thickness and tissue quality and dimpling and, like you said, fat retention, and the fat's sometimes thicker on the outer thigh than the inner thigh, and you're like, oh my gosh, you got contour problems. Like it is it can be a big black hole if you start going down it in the wrong direction.
Yeah. And it's also not even that, but with age, the descent, like the actual dropping of the front portion of the thighs. And I've had a couple of patients who come in who are very fit, not overweight, have never had weight issues, and they've got, a fold of skin sitting above the knees. And they're like, what am I supposed to do with all of this? Because when they pull up on the skin, they're pulling up, 2 centimeters, couple of inches of skin to really unfurl all of that. And I mean, you can treat thighs with Renuvion, but I don't think you get that significant of a vertical pull from that. It's more helpful in the inner thighs when you're doing liposuction, but I feel like that's a tough thing as well. And I've seen people try to address it with threads, with like PDO threads. Have you seen this before? People try to do PDO threads at the front of the thigh.
It makes sense, taking a barb, and try to just grab everything and pull it up.
Yeah, but
good thought
I don't
process.
think it's necessarily just a redistribution is going to be effective, because it really seems to be of significant excess. But unless you're going to put a scar on the front of the thigh to like lift that whole thing up, that's not something you're going to see a significant change for. It's just tough. Thighs are tough. Who's the thigh expert out there? We should get them on the podcast. Who is the thigh person? Let us know what the future of thighs is going to be. Take us into the future, 2025 and beyond.
2025 thighs.
The future of thighs. Let's make thighs the new thing.
It'll trend.
It's like we go from Whoville nose in 2024 to, I don't know who's that. Is it still Barbie's thighs? I'm not sure who's gonna.
Who's got the model thighs?
Whose thighs are we aiming for? Although Barbie is she's supposedly like 7 feet tall or something. When you look at her proportions, I think she's like super
she's gonna have
tall.
severe hang of that skin when she gets older. It's a lot of skin to hang.
Yeah, but I feel like that's a tough one. I feel like at some point, the minimally invasive technology, Renuvion, Vaser, as we continue to see iterations moving towards the future, these areas that are not really good candidates for a lot of the excisional procedures that we have, we're going to start to see them to be much more effective, so a much more appropriate case, or things that we can really do for things where, like, when somebody comes with that problem, I'm like, I don't know. I'm not sure that we really have something that's really going to crack this whole thing from start to finish, instead of having to tell them like what we can do and what we can't do to prepare them for what the future will bring. I feel like at some point the tech's going to get there where we're like, this is something we can knock out of the park. I finally have something in my hand that's going to get it taken care of. And I think that this is one of the things I talk about with all these minimally invasive things. There's so much tech, right? We have laser lipo, we have suction assisted, we have power assisted, we got Vaser, we got Renuvion. Whatever is in that equation, it is never any better than the person who is wielding it, how much experience they have and how much they care, because they have to have both of those things. Because there's some people who do a ton of liposuction and they're not interested in giving you like a super stellar result. Like that's not the business that they're running. They're just trying to like pound through it. And I see a ton of like horrific liposuction. I'm sure you see it as well. And when you see some of these patients, you're like, well, they have created like a near unfixable issue. I can't just touch it up with lipo, because everybody's like, well, I had bad lipo, so if you could just do really good lipo and make this better. I'm like, that's not going to fly. We always have to do something more significant to address it. But if people don't have experience and they don't really care about what your result's going to look like, you're not going to have a super stellar result. And I think that when you're doing liposuction, when I was in residency, when you're watching people wave a magic cannula to like have fat removed, you're like, well, that looks straightforward, right? That doesn't look like a difficult procedure, but there is so much finesse that goes into it. And the fact that when you're doing it, people are like, oh, it's like sculpting. I'm like, it is not like sculpting, right? Because if it's sculpting, if I have like a block of marble and I'm just going to chisel out David, when I'm done, it's going to look like David, right? It's like, I know when I'm done because it's like, oh, this looks great. We're all done with it. But with lipo, everything is swollen, right? Everything's blown up. Everything's distorted.
David didn't swell.
Yeah. So it's like trying to sculpt David, but David is covered with like a sheet. So you can't actually see what you're up to. It's like you're feeling with your hands and you're pinching, you're looking at things, but you don't really know until you like pull the sheet away. And that's really what it comes down to. And when people start to understand, they're like, hey, you're not seeing it in real time. You can understand how incredibly difficult that process is to get you what you really want. The tech is helpful, but the person who's doing it has to be good at what they're up to.
It's true. I mean, you literally are like having to kind of, again, we talked earlier about the subconscious. You're pinching and you're using all this tactile feedback. You're using your experience. You're visually trying to figure out what's going on under the sheet, but you're kind of feeling and doing all these things. You're looking at volumes and you're taking educated, guesses at how it's gonna look in 6 months to a year. And yeah, I mean, I think sometimes, I compare it to like when you used to watch Michael Phelps swim, you're like, man, this guy makes it look easy. But if you actually were there, you knew everything he went through, the training or what's going through his mind and his body and his processes, like you'd just be like, this is wild, dude. Like, how is this even humanly possible, what he's achieving, And I think, what we do a lot of times, we post the befores and afters. And I think there's definitely a lot of technical aspects to it. Again, on the mental side, the physical side, the guesswork with the sheets and all that stuff with carving David. And you see the result on Instagram or whatever, but it's like, no one really sees that aspect that you're talking about, really thinks about it.
Yeah, it's a tough thing. I think that it is something that is widely overused, right? There's so many places that they only do liposuction, so when you show up to them, you will get liposuction, whether you're a good candidate or not, because that's all they've got. But you see so many patients come through who had lipo, who just needed a tummy tuck or whatever it may be, and they never had the right surgery out of the gate. So now you're like, oh, well, now I have to have this more expensive surgery to cover up this other surgery that was not free, when they should have just had that from the get-go, and they would have saved a bunch of money of just doing the right thing. But it's overused. Very few people are like the best candidate for liposuction, and you have to have all the tools at your disposal to get a good result. It is tough. It's tough.
Well, and one thing I was telling a patient today at clinic, and we push our boundaries as far as we can safely, right? Meaning, like, I lipo to the point of where I'm like, if I do a little bit more, the skin is not going to survive, type of a thing, right? But I do that because if I don't do that, we're not going to get the contour that we're hoping for. Like, I think, not saying you have to go extreme, but we are always like, we have to walk this very, very fine line of like, if we go a little bit more, it's too much, but anything less than that, it's not enough, right? And to me, that's when it's like you're finessing what you're doing, and you're kind of honing in on, what your reproducibility of results and getting those results your patients want. But it's scary. And sometimes, as you're trying to navigate that line and figure where that is for you and your own techniques, like, I've had patients who had lipo burns, because they get compression after and it's just too tight and they're swollen. And you have to treat those things. And that's the reality of it. There's nothing is without complication. Now you can avoid, obviously like perforating bowel and doing those things. But, I think I think of like, these high definition like warriors that are doing HD lipo, right? Like they're doing HBO therapy. They send their patients to hyperbaric oxygen 5 days in a row. After surgery, they're hyperbaric every day because they've done that. They've pushed it so far that there's literally no fat left in certain areas, and it's just skin. And that skin is like, please give me oxygen, And so that is definitely a thing. I don't do that, but it's interesting to see like the spectrum of the lipo that's out there. Like you said, some people are just lipoing to lipo. Some people are really like I mean, in a way, sculpting, like you're saying, like David, underneath a sheet and doing it very well. So it's cool, and for me, it's admirable to see surgeons that are capable of doing that, and I aspire to that.
Yeah. I think it's an important thing that they put out there, talking about being a safe plastic surgeon, right? Because I think that in other forms of surgery, we're like, if you're being safe when you're taking out someone's appendix, it's like you're just doing it safely, you're just finishing, patient moves on. For us, if you are too conservative, you are too safe, you're taking out less tissue, you're undermining less, you're moving things less because you're worried about having a problem, all of your patients will be destined to be underdone, right? It's like everybody will come out with a little bit of extra skin or a little bit of extra fat, and you just have patients who will be like mildly unhappy. You won't have the person who's like desperately unhappy because something significant happened, but you're being like ultra conservative and ultra safe. Finding that balance of trying to figure out what you can get done safely in your hands with your patient population, with the kind of recovery style that you have, is a really important part of what we do, because you don't want to underdo everybody. At the same time, you can't super push the envelope and have patients who are having really super significant complications, because you don't want that for your patients. You don't want that for your staff. You don't want that for yourself. It's like losing sleep over it. So trying to strike that balance, getting the kind of result that you're after, but doing so consistently and safely, means that you're going to be towing a line that from time to time you will have a misstep, and then you will look back and be like, what is the reasoning behind this? Was this a compression issue? Was this a patient selection issue? And figuring out what you're going to do to avoid it in the future. And I feel like a good portion of that isn't something that you see on paper, is just this general vibe that you get for certain patients. You're like, I feel like this person, and I don't know why, is likely to be a problem, and I need to like ease off what I do a little bit to make sure that they have a smooth ride. Yeah. And it's not something that's on paperwork. It's not something that somebody's teaching you. You've learned with time what you can kind of get away with. And that's when the experience comes in. Totally. It's like, as plastic surgeons in general, it's like we're forced within our time, not because we're doing it for research purposes, but for our practice to optimize our results, we're always asked to kind of toe the line of safety. So it's like, you want to be a safe surgeon, but you don't want to be too safe.
Yeah. Totally. I mean, and that's like, I think you talk about like, as you're, the more experience you have, the more you kind of get this gauge that you're talking about, where it's this kind of unspoken, like, how much can I do on this patient? You develop those skills. But it's like, it's these iterations over time. I think of like, even like my breast augmentation practice. I mean, I'm pretty much all subfascial now, no muscle cutting, with internal bra and all that stuff. And that took me about 2 years to get to that point, where I felt like, okay, I'm going to the point where I feel very comfortable. I'm getting consistent results. I don't need to, adjust or do anything. And again, it wasn't experimental, but it's like I slowly did that, so I didn't have to have any major complications. There were no major complications, right? It's like little things happened here and there as you're fine-tuning things in your process. But now I'm at the point where like, it's great and I'm happy. But then I'm always like, what's the next thing I can learn? Because I also get bored easily, right? Not that I'm bored, but I want to make sure I'm always, again, doing what's potentially the best for my patients, the safest, and, safest but not too safe, right? Like always safe, but
safe, but
again,
not too
giving
safe.
them result. Definitely safe, but not where they're like, why did you didn't do anything? You took off 200 cc's of fat. You could have taken 2 liters.
Helpful. Yeah. No, and I think for some of these things, right, when you're talking about breast augmentations, you're not talking about super major complications. I think the biggest no-no for breast surgery is reoperation. Be that for wrong size, wrong style. Anytime you have to take a patient back, it's very uncomfortable both for you and for the patient to try to figure out like, what's that going to look like financially? Are you going to give free implants? Are you going to comp your time? There's more downtime for them. They're really, especially with the breast augmentation, looking for like a one and done surgery for a decade to a decade and a half. And it's just not what their expectation is in general. So while you don't have, necrosis, tissue death from, breast augmentations. I think that is like the gold standard of like, am I doing the right surgery? Am I having to go back with any regularity? And can I make that better towards the future?
Yeah, I think it's important for us. Even we're not in academics technically, right? We're in private practice, but like I look back at my own cases, and I went through all of my Galaflex cases, for the first 4 years. I had some pre-med. You and I are working on some stuff with this, but to look back at almost 700 patients and then, evaluate myself like, okay, how many times did I have to go back for revisions? And did that happen more in the beginning and less now? And, what were they for? Were they major, minor complications, right? Like I want to look back at my own data and get feedback from my own technique so that I can either adjust it or continue to do things that are working, So I think that's super important for us as surgeons to look at that.
Yeah, if you're not looking back, it's tough for you to grow, because if you're not looking at numbers, you're just doing it based on your feelings, and that is not necessarily ever helpful.
It's great. Yeah, totally.
I feel like some of us grow. It's like you have these times you're like, oh, it's the beginning of the year. I'm going to look back at my last year of top surgery or tummy tucks or whatever to look at how things went, how my results are looking, look at the photos, see what I could be doing better, see what I'm nailing compared to the year before. But every once in a while, we learn because of a singular patient. I'm sure you've had this happen before, where you've had a patient that something happened to them, may not even be your fault, maybe something kind of around it, or how the patient healed, or their aftercare, whatever it may be. But the outcome of it was significant enough, you're like, that is going to change my game plan for this forever. Like, I don't have to wait a year to look back on my numbers. I'm like, I want this to never occur again. Because I had a patient that I did a small volume breast reduction on. It was mostly a lift, and she looked gorgeous at like 4 to 6 weeks. I'm like, I'm patting myself on the back. Like, this is a absolutely stellar result. And then a couple of months later, she came back. We had lost touch for a little bit. I think she missed one of her appointments. I'm not sure. But basically in that like 2 to 3 months range, we didn't see her for a while. And then when she came back, she had horrible keloids, like the worst keloids I have ever seen. And she was of lighter skin tone. She's not someone that I was like super worried. She didn't have a history of it. It's not something we're tracking her for. But her keloids were like 1.5 centimeters across, and like so deep red they were purple. It was crazy. I've never seen anything like it, and I haven't seen anything since. It's been a couple of years since. So we started doing steroid injections like as soon as we saw it, and we went over rounds and rounds and rounds and rounds of injections. But when a scar is that wide, even when you get the injection to get the keloid to come down, you have widened the scar so much that you lose your lift and things have dropped down. And I talked to her when we got to the end of all the injections. I was like, well, I can revise all of your scars and we can send you to radiation therapy to dial things in. That's the only thing that I think is going to be helpful given how bad it was, because it's the worst keloids I've ever seen. And she was like, no. She's like, I'm not going through this again. Like, I'm not happy with the results. It like affected her mental health, but she couldn't bring herself to kind of go through that process. And I really, really feel for her, and I would love at some point if in the future she was like, hey, I want you to revise these scars. So I'm like, I'll do it for free, right? It's like, I've been so worried about her for so long. I want to do the best by her, but she specifically is the reason why I see people 6 weeks, 3 months, 6 months. I want to make sure that no one vanishes for like a while and I'm not seeing them for a longer period of time, because when something like that's happening, I need to know immediately so I can jump on it. Because as bad as her scars were, she didn't feel compelled to come in like super soon when that started happening. She just kind of thought it was part of the healing process. And it's like, if I had seen her or laid eyes on her during that time when it first started, it's like we could have saved that result. And I was like, forevermore, I'm seeing everybody more. There's no way around it. But you have some of those people who are like an index case that you're like, I have learned something and I'll never let this occur to my patient, their family, myself, or my staff ever again.
Yeah. Totally. I think, all surgeons have that. And sometimes, like you said, it's an experience that you've had that maybe I haven't had. Doesn't mean that because you've had it, I'm going to do that, right? Because our practice, we're all a little different. but I'm going to have like those index, like, patients where same thing. Like I may now for all of my patients, I check, whatever clotting labs because one patient, had a bleeding disorder we didn't know about, whatever it is. Right. Yeah, I agree. And you're in a big practice too. And so what I've tried to do in ours, because we have 4 surgeons in our small practice, but is to really try to standardize even like for our team. Like if we're all doing labs for our, let's say, mommy makeover patients, we're checking pretty much all the same labs for all the surgeons, just so it's easier for them, so nothing's ever dropped out or lost. Like if I have a certain labs that I want, and then Dr. Garlic has his, and Dr. Piper, like I don't want the staff to get confused and be like, so wait, which doctor orders what, and then we're missing out. So I'm more of the philosophy of like, look, if more is better for everyone or whatever, less is better, like I'm fine with that because I think it makes everything a little more cohesive and easier for people.
Yeah. At least discuss it, right? And then the other people in the practice, if something changes, the other people can learn from it as well.
Totally.